Alright, I'm going to show you an easy way of visualizing three classic healthcare systems. We know in the United States we have a bunch of different healthcare systems that are all working alongside one another, serving different populations. The first healthcare system we'll look at is going to be the single-payer healthcare system, which is used in Canada. It's also the structure of traditional Medicare in the United States. The second classic healthcare system we'll look at is going to be the Beveridge model, which is used in the United Kingdom, and it's also the structure we have for the Veterans Affairs system in the United States. And the third healthcare system we'll look at will be the Bismarck model, which is Germany's healthcare system, and it's also similar to Medicare Advantage in the United States. And really the way of thinking about this is we've got these different players in the healthcare system. We've got the government, we've got insurers, we've got doctors and hospitals, which are providers, and of course providers includes more than that, but for now we'll just represent those two players. And then we have people. Let's start out with the single-payer healthcare system. So what does that look like if we look at these players? That looks like this. A single-payer healthcare system is just a system where the government acts as the insurer. That's it. So the government does not own the doctors and hospitals. Those operate separately. Now the government is going to negotiate with those just like any insurance company will negotiate with those. The government can, if it wants to, set prices for doctors. So it has certainly controls and ways of influencing heavily doctors and hospitals. And if the government is the only insurer in the country, then of course this government insurer has monopsony power. Monopsony power is when there's a single buyer who's purchasing doctor services or hospital services. So that comes along with economic power in and of itself. But the key here is that with single payer, the government is the insurer, runs the insurance company, but it does not directly own or run doctors and hospitals. Now, there's variations in the way single-payer healthcare systems work. For example, you could have a government that allows different companies, and these could be for-profit or they could be not-for-profit, to bid on which company is going to run the government's single-payer healthcare system. This was something that Vermont looked at doing when it considered doing a single-payer healthcare system a few years ago. It would basically, instead of having the state run the system, the state would put out a call for proposals, and insurance companies would submit their proposals explaining how they would run the single-payer healthcare system, which would be overseen by the government but not directly run by the government. So that's just sort of outsourcing the running of the government-run health insurance company. Or the government could directly run the health insurance company. There's lots of different setups when it comes to how you actually handle the management of a single-payer healthcare system, but the big thing about single-payer healthcare systems is that the government is the insurer, is the payer of doctors and hospitals. The second healthcare system I'd like to talk about is the Beveridge system, which is the system used in the United Kingdom. And in the United States, the Veteran Affairs system is also follows the Beveridge system. So how do we visualize this system? The Beveridge model of the healthcare system is where the healthcare system is run by the government. So the doctors can be employed by the government, the hospitals are owned by the government is the insurer and the provider for people. Now, the government can run this system however it wants to. So if we think about a corporation, and the CEO of a corporation is allowed to take certain parts of the business and outsource them or hire a different firm to take care of that portion of the business's operations. That can also happen with a Beveridge system. So if it wanted to, the government could say, okay, we're going to give each state or each region a chunk of money to handle hospitals in that region, and not-for-profit organizations in that region are going to decide how to run and how to manage hospitals in that region. That could still happen under a Beveridge system, and increasingly it does. The United Kingdom's healthcare system involves a lot of experimentation with how do you structure the management of this system, but the basic idea is that everything is under the control of the government. Now, one thing I should mention with respect to both single-payer and the Beveridge system is that you can have private insurance companies operating on top of that. So in the United Kingdom, everybody has the health insurance that's provided by the government. But if you don't like the wait lines or you want a cancer drug that the government has determined is not covered by the government insurance, you are allowed to go out and buy private insurance, which gives you access to extra services. Now, in contrast, when we look at Canada's single-payer healthcare system, they have a law that does not allow citizens to go out and buy private coverage for any service provided by the government. Now, you can buy private coverage in Canada for things that are not covered by government insurance, but you can't sort of get the special treatment, the VIP treatment for something that people under the government service have. So there's lots of different setups for rules and regulations about whether or not private insurance companies operate on top of the government-run insurance. So the big picture 10,000-foot view of the system does not get into some of the really important details that might go along to make a healthcare system work or not work. Alright, the third healthcare system we're going to look at is the Bismarck Health Care System. This is the healthcare system in Germany, and it's also the way Medicare Advantage works in the United States. And of course, Medicare Advantage is what people over 65 can get if they choose to opt out of traditional Medicare and opt into Medicare Advantage. So basically, if you're over 65 in the United States, you get to choose either Canada's system or Germany's system, whichever you prefer. Now, I'm going to explain this using a different diagram that I think is more helpful, but just to make it parallel with my other two explanations, I think we can look at this map first. So how this works is people, of course, pay money into the government, and this could be through taxes, or it could be that you opt into this system by paying a certain percentage of your income, as happens in Germany, and then the government issues each person a voucher based on their risk type. And that voucher can be taken to any insurance company. Now in Germany, the insurance companies cannot be for-profit. They have to be not-for-profit. But you could set up this system with for-profit companies as well. And the person gets to look at all the insurers out there and choose the one they like best, and that insurer has to accept their voucher, which is risk-adjusted, meaning that voucher gives the insurer more money if the person is sicker, and it gives them less money if the person's healthier. Alright, this is the way I like to explain the Bismarck system. So we have people with different health statuses. So we have someone with cancer, someone who's healthy, someone with diabetes, and they have different amounts of income as well. Now in Germany, you pay in a certain share of your income to the government if you want to opt into the government pool, the government system. So if that share is 15%, then this cancer patient pays 15% no matter what their income. If they make zero, they pay in zero. If they make 100,000, they pay in 15,000. So once the government collects this money, the government has this big pool of money, and it doesn't connect the money to the person who paid in. It creates a voucher for that money. And I'm using voucher as a way of visualizing this. That's the best way of describing it. They might not actually receive a physical piece of paper because everything's done electronically, but essentially it acts like a voucher. So the government creates a voucher for each person based on their risk type. So someone with cancer, their voucher is going to be for a higher dollar amount because each insurer who takes this person is going to be expected to pay out a lot more for their care. So if we don't adjust the vouchers for how sick the person is, then insurance companies are going to try to avoid the cancer patients. And how do you do that? You do that by offering lower quality cancer care. I talk about that in other videos, but you need to adjust these vouchers for the health status. So the government has a bunch of statisticians that calculate that voucher. So in this case, the cancer patient gets a voucher that's for $200,000 that can be redeemed at any insurance company that meets the government standards. The healthy person has a voucher for $100, which is the expected cost of covering healthcare that year for the healthy person, and the diabetes person has a voucher for $20,000 the expected cost of covering their care for the year. And they can take that voucher to whatever insurer they want to. So for example, this cancer patient might choose insurer A. The healthy person might choose insurance A as well. And maybe the diabetes patient is going to choose insurance company B. So there's still competition in the system between these insurance companies that essentially, what are these insurance companies trying to do? They're trying to maximize number of people attracted to their plan. Of course, they could have other objectives as well, but there is this competition built into the system. Now, in Germany, you are allowed to get private insurance if you opt out of the government pool. So you, let's say the diabetes patient did not like their insurer and they were sort of done with government provided health care. That person can say, nope, I'm no longer paying the 15% to the government. I no longer get the voucher. Instead, I'm taking my business to a private insurance company, and that's allowed. Now, of course, you can have Bismarck systems that don't allow for that. There's lots of different setups with respect to private insurers and whether they're allowed, what exactly they're allowed to do. But this is the basic setup of the Bismarck Health Care System. Basically, it's a system where people pay in a certain share of their income, they get a voucher that's adjusted for their health risk, and they take that voucher to insurance companies. And it's also worth mentioning with these healthcare systems that how a healthcare system works and plays out depends on a lot more than the overall structure of the healthcare system. It depends on the types of regulations, it depends on price regulation. You can add price regulation on top of any healthcare system, no matter how it's structured. So there's actually a lot of factors that go into making up a healthcare system. Really, the devil is in the details. How do you incentivize doctors in a healthcare system? Do you have programs to promote to reward doctors for good quality care? What are the paradoxes involved in that? All of those decisions about how things are run at the level of the provider and how things get paid and when does money change hands, all of those little decisions matter a lot. And those little decisions do not always depend heavily on the overall healthcare system. So sometimes I think people assume that if you get the overall structure of the healthcare system right, everything's going to be fine. That's really not the case. You have to learn a lot about the details of healthcare economics if you're going to think about what will actually make a functioning healthcare system.